Hello, thank you for joining this AI Med live webinar. My name is Alexis May, Director of Content at AI Med, and I'm pleased to be joined today by an outstanding panel of experts as we discuss artificial intelligence and its impact in the domain of medical imaging. There's huge and demonstrable potential to save analysis and reporting time, making a positive impact on physician workloads. And in today's session, our panel will focus on AI developments in cardiovascular imaging, offering some insights around the integration of AI into the clinical workflow. Now, please do feel free to use the questions tab on your screen. We will have between 5 and 10 minutes, hopefully, for Q&A at the end of the session. For now, though, without further ado, I'd like to introduce our first speaker today, John Paul Carpenter, who is a consultant cardiologist with a specific interest in cardiovascular imaging, including echocardiography, cardiac CT, and cardiovascular MRI. JP, I'm just going to get your slides up quickly and we're going to be good to go.
Just like to say hello.
To you whenever you're ready.
Presentation, which I'm going to talk about imaging, in particular reference to cardiac MRI. I have a disclosure to make that I'm a customer of Circle Cardiovascular Imaging and I'm a member of their power user group. Where it all starts is really with the UK Biobank. Now, this is a huge study which is looking to recruit 500,000 individuals over the next few years, normal subjects between the age of 40 to 69, including a lot of demographic, lifestyle data, ECG, electronic health records, genetics, and biomarkers. As part of this, there is an imaging sub-study where we're looking at 100,000 studies of MRI, some ultrasound, DEXA scans, etc. And so far, about 47,000 patients have been scanned as part of this. Why, you might ask? Well, what I'm going to talk about is the MRI protocol, which is a relatively abbreviated protocol, not performed in a hospital environment. It's done in specific imaging centers in industrial estate, for instance, where patients don't need intravenous contrasts. They're just having cine scans, tagging, flow, native T1 mapping, and an axial slice for aortic distensibility. So a very abbreviated protocol which doesn't need medical input. From this, 5,000 of the studies, in conjunction with Stefan Peterson at Queen Mary University in London, Stefan Piechnik in Oxford, and Stefan Neubauer also in Oxford, they back in 2017 looked at how you could use this to segment and train a deep learning system, convolutional neural network, in order to analyze MRI scans rapidly and reproducibly. This is the result, where you can see a short axis of images, same case on the left as on the right, from base to apex, and you see the endocardial and the epicardial borders of the left ventricle as well as the endocardial border of the right ventricle outlined. Essentially, you can decide whether you have smoothed contours or whether you include the direculations and the muscles within the blood pool or within the myocardium, but you need to do that. That's a user-defined decision. What we used to do was draw around each of these by hand. Is extremely time consuming, and just drawing circles when you're a highly trained individual with very little time needs to stop. We cannot carry on doing that, so having solutions such as this will help save time, save money. So how much time does it save? Well, if you're trying to do it via a very rigorous protocol and you delineate end diastole and end systole in the left ventricle, in the right ventricle, in the right atrium, the left atrium, you're looking at between 17 and 32 minutes. It took the computer 21 seconds using a graphics processing unit to look at 50 time frames. So that's not just end diastole and end systole, much more data and a fraction of the time. 8 expert human analysts in the original data set took 7 months. the deep neural network took less than 1 week once it had been learned and trained on this data set. Essentially, from the clinician's point of view, it just works. And the concern is, if you're just pressing a single button, won't we be out of a job? Why are we needed? Well, we are needed to analyze and to look at these scans. It's very effective, efficient, it helps with time constraints, and essentially you just need end diastole and end systole to look at the LV ejection fraction. We are looking at pattern recognition, and for us it's very easy to tell which of these pictures is a cat, which is a croissant, but for a computer that pattern recognition is extremely complex, and previous edge detection algorithms just did not work, were not possible to get this with any degree of efficiency or accuracy. Why are we looking at pattern recognition? Well, when the system loads up, it will automatically identify different image sets. It'll load them into the automated function modules. It'll already have, could I ask Addy, could you turn your microphone off, please? Many thanks, because I'm getting some other noise on the system. Okay, sorry, just to go back. When the system loads up, it automatically identifies the images, it loads them automatically into the modules, automatically generates the contouring before you've even opened the set of data, and will get your signal intensities correct for all of these sequences. There's a lot of pre-processing which is done before you even look at the study that you're trying to analyze. You can look at functions, so you'll look at end diastole, end systole. You can get the system to generate contours for the whole of the cardiac cycle. It will use AI tracking for the valve plane in 4D flow. You can also, in development, do it automated tracking for aorta and for the pulmonary artery, and trace both the left and the right atrium, which again, for all time points in the whole cardiac cycle, would be extremely onerous and take you a huge amount of time. It'll also translate those contours so that they're automated for the mapping sequences, allowing you to save time. You don't have to trace all of the contours again for T1 and T2. What I was talking about, not just end diastole and end systole, you can look at all time points in the cardiac cycle, so you can be absolutely sure that you've got end diastole, you can absolutely be sure that you've got end systole to get the correct ejection fraction, and even look at the filling points during diastole to assess diastology if you would like to. It will allow you to track the contours for strain analysis, which is one of the other plugins available within CVI 42. And this tissue tracking analysis gives pretty good representation of global longitudinal strain as well as circumferential and radial strain. The 5,000 data sets were also used to generate a new set of normal ranges. And so we've got, a normal zone for left ventricle, for LV, end diastolic volume, etc., and abnormal low, abnormal high. The thing about the computer system is that every time it does the analysis, it's going to be doing exactly the same thing, so we don't have to worry about the inter-observer variability between studies or between individuals. Whereas for a human observer doing all of this, it could take up to 19 minutes or so. The AI algorithm has already loaded everything. It's already done all the contouring before you even open the data set to review within the system. And there is pretty close agreement between the volumes and the function between human observers and the automated system. So what are the advantages? Well, for research point of view, it's the longitudinal follow-up. It's looking at large samples of data. So for instance, within the imaging sub-study in the biobank, there's 100,000 scans which you're trying to analyze, and all of this would be impossible to do manually. It allows you to follow up patients clinically. It allows you to reduce your sample size for heart failure studies, for instance. And as I said, there is no variability because the computer will always do the same thing each time. It also allows you to save time, to save cost. And if we look at the US, for instance, non-contrast MRI is pretty badly reimbursed. So in the US, there's a physician reimbursement and also a technical component. Some of this may be slightly historic funding data, but the technical component of the scan has been going down and down and down over the last few years, such that it's $230 in 2019 versus myocardial perfusion scanning, $1,200 or so. So, you know, much less in terms of payment, and all of that has got to pay for the time, the scanning, the radiographers, and you're not left with much. And if you can do this very quickly, then it will help in terms of throughput and the cost saving. So does it work in clinical practice? I'm just going to run through a couple of examples from that point of view. If you have highly abnormal pathology, can the computer still recognize it? So hypertrophic cardiomyopathy with huge septum, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, Takotsubo, pulmonary hypertension, Fabry's disease, sarcoid, and amyloid all give you different hearts, different appearances. And the original 5,000 data set, remember, was only looking at true normal patients, or sorry, subjects in the biobank. I tested this myself on my own data sets, and we can see that even though this system is trained on, in inverted commas, normals, it will pick up the contours very accurately with pathology. The system has subsequently been updated such that there are now 20,000 cases on which it's learned, including pathologies such as DCM, HCM, etc. In this case, it's severe LV impairment, and you may notice that there is some discrepancy at the apex and the base, but actually that's going to make minimal difference to your analysis as you go through. Even if you were to remove those bits which don't look like they're tracing correctly, you'll make a minimal change to your contouring. That's dilated cardiomyopathy. This is hypertrophic cardiomyopathy with significant LV hypertrophy and late enhancement in the septum. It still traces the endocardium very nicely. The next case is a huge apical thrombus, and again, it traces everything really nicely. It makes a slight error at the apex, which isn't going to affect things very much. I tried to confuse it by looking at a pericardial effusion. It can still pick out the heart very nicely, bicuspid aortic valve, LV impairment, and pericardial effusion in this case. What about if you have apical hypertrophic cardiomyopathy? Again, it picks out the contours very nicely. This is Sjögren-Strauss, or eosinophilic granulomatosis with polyangiitis, as it should be called, large endomyocardial fibrosis and thrombus within the right ventricle. And again, it picks out the contours very well, just making slight error at the apex. What about if you've got a hugely dilated esophagus? Again, it can pick out the heart in this situation. And we also know that we can make massive speed up factors in terms of the MRI scanning itself. On the left, you've got a conventional SSFP, so a breath hold sequence for each slice, takes 5 or 6 minutes. On the right, this is a single breath hold compressed sense acquisition, which takes 10 seconds. So slight reduction in terms of the image quality, but actually, 10 seconds versus 6 minutes and no time at all with the AI solution doing the analysis. You can see the time savings that this is going to give you. Compressed sensing also works really well with arrhythmias. So on the left-hand side, this is a patient with atrial fibrillation. There's lots of misregistration artifacts. On the right-hand side, the compressed sense acquisition actually works even better, and you get very similar analysis in terms of the volumes and function with 45% ejection fraction on both of these. So the speed up factor is going to be of absolute paramount importance. What are we going to be able to do? Well, essentially, Circle are working with Siemens to develop automated protocols where all the user has to do is to put ECG stickers on, the patient goes into the scanner is able just to scan the whole thing without very much user interaction. You can have a 3D acquisition which has all the volumes, the flow, the T1 mapping, and there is essentially very little that needs doing. You then drag and drop all of the images into an analysis package. It can potentially fully analyze everything. Even quantitative perfusion is in the pipeline, latent enhancement, mapping. And then in process are systems which can automatically populate a report with the data, and based on what the system finds, provide you with a report with natural language generation, so that all the radiologist or the cardiologist has to do is to use a final check. And this is not that far off, and there are systems now which can do this. How will that help us in the end? It will be able to allow us to have decision-making and management algorithms with clinical decision support engines. You're not removing the doctor completely, but you're giving all the possible support and clues regarding the correct diagnosis and the correct pathology, which will help, removing the variability essentially. Eric Topol was asked by the UK government to prepare a report to look at the digital future going ahead, and his estimation was that we'll have automated image interpretation using AI in 2040 for 80% of studies. I think we'll get it an awful lot quicker than that. For instance, Mount Sinai has got a clip merge system where there is genetic data on most patients, and if you choose a drug which suggests that that may not work so effectively, there's a little warning which will tell you, okay, clopidogrel may not be the best thing to use here, try prasugrel or ticagrelor. And we may end up in a situation where we have this very helpful, useful tool to allow us to make clinical decisions when we're face-to-face with patients. The NIH is running All of Us research program, which is a similar thing where they're looking to recruit 1 million patients across the US and look at environmental factors, lifestyle factors, and biology to determine how we pick up disease going forwards. Verily, which used to be called Google Life Sciences, is part of the Alphabet and Google group. So in summary, from the MRI point of view, this is got a huge potential for time and cost savings. It's very advantageous from a clinician side of things because actually the boring bit is drawing all the circles. What you want is to be able to just go in and make a spot diagnosis and verify your report is okay. We know it's robust and accurate. Omar will talk a little bit more about validation. And it's not just a black box system. We could have images acquired into K-space on MRI. The computer could analyze K-space. We don't need the images and it could just give us a report. But actually having that user interaction and the robust side behind it allows us to know that what we're looking at is correct. And from my point of view, it's a huge benefit going forwards. I'd like to thank Stefan Peterson and the BARTS team. I'd also like to thank Daniel Light from Circle for asking me to talk, and we can have questions later on. Alexis, back over to you.
Thanks so much, JP, for a great start to this session. As mentioned, indeed, we will run through questions at the end of the session. Thanks for the ones that we've had so far. Next up is Omar Mohammed, a senior research developer in machine learning at Circle Cardiovascular Imaging. His research is focused on developing automated solutions for CMR imaging protocols. Omar, let's get your slides up. Let's give you control. And whenever you're ready, please take it away.
Thank you, Alexis, for the introduction. So I'll talk about some of the advancements we have been doing at the machine learning group at Circle Cardiovascular Imaging in the domains of CT, MR, and some of the validation strategies that we have developed over the time. That includes clinicians in the loop to help our development. So let's look into the AI advancements in the cardiac CT. So I would like to start with a quick overview of the motivation behind automated image-based coronary analysis. Indeed, the use of cardiac CT is on the rise for diagnosis of the coronary arteries. However, as John mentioned, that this is a manual, laborious process, and as it can be appreciated that the CT scans are 3D structures, huge volumes. So it takes a lot of manual efforts to annotate the complex 3D structures. So we believe that the automation will lead to wider adoption of the non-invasive coronary artery disease diagnosis. So these automations can be first used to locate the coronary arteries. Once the location of the arteries is determined, we can run some plaque analysis to quantify the stenosis, and that can help us to predict the disease outcomes. So now let's take a talk about why manual analysis is so challenging. This is important as these challenges directly translate to challenges in automation as well. So coronary arteries are hard to detect accurately due to, of course, the complexity of the 3D structures and large variations in the patient anatomy and pathology. And this is further exacerbated by the presence of different tricky imaging artifacts, including the stepping and motion artifacts, and lack of contrast. Annotations, of course, are very expensive to go through the 3D structures and annotating these small structures across the whole entire volume. So so here we can use the power of machine learning to speed up the process, but we need to focus on the motivation of using machine learning. Do we want to make a system that acts as a black box? It takes in the grayscale signal intensities of the volume and convert them into CAD report. But that's not a motivation behind our development. So we want the clinicians to be able to interrogate the determinations made by an AI algorithm. And our primary goal, just to repeat, is to automate the tedious task and not to lock experts out of the process. So here, what we mean by the intermediate steps. So that involves the use of machine learning in localizing the coronary arteries and visually displaying them so that the user has the power to make any corrections or adjustments, and they will be reflected in the final reports. So here we are showing how the system works. It detects the center line of the coronaries, and then it displays in the all MPR frames and also the 3D visualization of the arteries. So in the first iteration of our algorithm, we were localizing only the major arteries, the LCX, LM, RCA, and the LAD. But we have been pushing the limits of the localization of the coronary arteries, and we want to make a system that can further localize the secondary arteries as well, so that any stenosis or any disease in down the stream can also be detected with the power of machine learning. So here we are showing the 3 major arteries in the red, yellow, and green colored, and all the other secondary arteries are shown in the orange color. Further, we want to extend it further, and we want all the primary or all the secondary arteries to be labeled as well, and that's the work that we have been doing over the past couple of months. So the next iteration of the algorithm is expected to output even the labels of the secondary arteries, the diagonals, and the marginals. So moving on, so once we have detected the location of the coronary arteries, we can also determine the plaque content that involves the calcium scoring. So we have developed a system that processes the NCCT, the non-contrast CT images, and output the pixel-wise labels of the calcified regions, including the LM, LAD, LCX, and RCA. And that is post-processed by the Hounsfield unit-based thresholding thresholding method to extract and quantify the calcium in the detected bundles. Here are some of the detections of our system. Here we are showing the detection in the RCA, and here the LAD. And so once we have labeled them and quantified their location, then our reporting can output each per vessel calcium quantification as well as the total Agatston score. So let's move on to some advancements we have been doing in the cardiac MR. So like John went over some of the other function-based automations. So recently we have also been developing methods to automate the 2D flow quantification. So we know that the blood flow analysis is most common with the 2D phase contrast MRIs, and it's important for many cardiovascular diseases. Sorry, it's going. So this requires automatic vessel contour detection of the phase contrast images in 2D. And deep learning can be used to support the flow assessment in a similar way that we have been doing in the function or mapping and modalities. So let's look at the system that we have developed for the automation. So this system, it comprises of the two stages. The first stage is to identify the flow series locations. So as we know that the for quantification of the flow requires the sinotabular, the segmentation of the aortic valve, which is the sinotabular junction, or the pulmonary artery. So in the first step, we want to classify the series. Once the classification is determined, we pass the aortic valve. We pass the images into specialized network that are trained to segment the aortic valve and the pulmonary valve. And once those are segmented, then the contours are passed to the automatic flow quantification system that detects all these metrics for flow, which include the net flow, and the peak flow, and the QPQS analysis. These are some of the results that we have for the aortic valve. So on the left, you see the phase contrast. On the right, the magnitude images for the aortic valve. On the right frames, we are showing the pulmonary valve that is contoured by our AI system. So for the performance validation, we have done studies with the Northwestern University, Dr. Michael Markle, and we did a first small study, which is 25 cases of clinical cases, and we proved that our automation works quite well in terms of the image processing based metrics such as DICE scores, achieving 90% performance. We extended the our validation onto like 75 further studies, include so in total 100 studies. Again, the 90% DICE score performance as well as the human level quantification of the net flow was achieved. So let's talk about some of the work that we have been doing to validate our methods, because in the past we have done extensive work on using image processing based metrics to validate the performance, including DICE scores, Hausdorff distance. But that does not involve any feedback from the clinicians. So we want them to be providing feedback in our development process as well, so that anything that we can pick up from their feedback, we can include readily in the development. So like I said, the traditional measures fail to capture the clinician's trust in automatically generated contours. And once the systems are deployed, then it's a tedious process of bringing the development process back to the drawing tables and do the whole iteration again. So we developed a simple tool to sample clinicians' trust as well as their feedback on manual and automated contours presented in a random order, and we do the extensive score analysis to see how does the automated contours rank as compared to the manual ones. So this is a simple graphical interface of the system that we have developed. It presents the MRI image to the user, and then the next image is showing the same image overlaid but a contour. It is instructing the rater to rate the image from the predefined score rubrics of 1 to 4, starting from the unacceptable, bad, fair, and good. Once and these images are presented in a random order, so the user does not know the source of the contour, is it manual or the automated. So some of the rating process is shown here. So this contour gets a score of 3. Moving on, this RV gets a score of 4. So these are some of the instances of the scores for LV, epi, and endo contours. So these are the perfect contours, but then these are like some of the contours that are missing some myocardial region. So assigning 2 score, or like a very bad contour or unacceptable 1 is assigned a 1 score. So we did this validation on a diverse data set that we received from the NHCS, the National Health Center Singapore. So it had a mix of pathologies including the healthy DCM, HCM, hypertension, IHD, LVNC, and the myocarditis. The total number of studies were 313, and that provided 3,400 images and 10,000 total contours. So with the manual and automated contours combined, so we have a total of 20,000 contours to be rated. We passed the tool along with this database of contours to the experts, and the total ratings that we received were about 51,000. So moving on to analysis of the scores. So here we see 4 raters and the distribution of the scores on the manual and automated contours. So we can see similar distributions of the manual and automated contours for the rater A, B, and C, and D as well. But if we look into the quality score of 3, we see that the manual ones are getting slightly higher distribution than the automated ones, which is a good sign that they're trusting our automated contours. Similarly, the rater C is also getting slightly better or lesser score 3 cases, which is indicating that the manual contours are having some automated contours are having some trust. So we also did some analysis on the various pathological cases to see if we are doing anything wrong in any of the pathologies. So we see a similar mean scores in the variance across the modalities, and that was also confirmed by John running experiments on his data with different clinical conditions. So we have published this work in one of the abstract, the EACVI European abstract, and then we have been expanding this work to a journal paper that is in the submission process. And that concludes my talk, and I'll be happy to answer any questions.
Thanks so much, Omer, for a great talk. Indeed, really well timed as well. Perfect. As mentioned, and thanks to everyone who sent through questions so far. We're compiling those, and we will get through as many as we have time for at the end of the session. For now, I'm going to introduce our next and final set of speakers. I'm just going to get there, make sure they have their slides ready to go. Bear with us 1 second. There we go, multitasking in a webinar sometimes can be a little challenging. We will be right with you. Here we go. So I'm now going to introduce our next speakers, Adi Hirsch, Head of Products at Daya. He specializes in AI-based solutions, enhancing both product performance and user experience. And Noah Liel, who's Associate Professor of Cardiology at the Faculty of Health Sciences, Ben-Gurion University, and the former head of echocardiography unit at the cardiology division at Soroka Medical Center. As co-founder of DIA, Professor Liel is actively participating in the process of developing new products and improving existing ones. So Adi, you're going to go first of all and hand over to Noah. I'm going to give you control and I will let you get on with it. Thank you both so much.
So yeah, thank you, Alexis. I'm taking control. So hi everyone, short introduction on DIA. DIA is the leading provider of ultrasound AI solutions. Our vision is to leverage AI to make the use and analysis of ultrasound images and accessible to all by using our AI-based solutions. And now I will go from vision to action. DIA7 ultrasound AI solutions are FDA cleared and CE marked. They can work on both prem and cloud. With access to more than 300K images taken from leading medical centers, DIA developed Elvivo solutions that are used by more than 3,000 users across 20 countries worldwide. Our fully automated echo workflow is called Elvivo Seamless. Elvivo Seamless works behind the scenes, right after an echo exam has been sent from an ultrasound device to a PACS server. By using its advanced AI algorithms, Elvivo Seamless automatically selects the optimal views among dozens of views included in a standard echo exam, and this way provides automated measurements for the clinician, avoiding the need for the cumbersome and time-consuming process doing it manually. These automatic measurements include ejection fraction, segmental and global longitudinal strain. Both are done from the LV, the left ventricle, and right ventricle, the RV. We have some measurement like TAPSE and free wall motion strain and more. Now we will see a short movie demonstrating DIA Elvivo solution. Alexis, if you can please play the movie.
After acquiring a full standard echo exam of 40 to 60 views, Elvivo Seamless runs behind the scenes to select the optimal cardiac ultrasound views and generate automated measurements of cardiac indications, such as ejection fraction and strain. The selected views with results are automatically presented on any radiology image viewer as a secondary capture, alongside a structured report on each Echo Lab cardiac exam in a fast, accurate, and objective way. Elvivo Seamless empower ultrasound users with AI.
Thank you, Alexis. At this point, I will hand over to Professor Emeritus Noah Liel Cohen from Ben-Gurion University at the Negev, and until recently the head of Echo Lab at Soroka Medical Center. Professor Liel will walk us through two interesting study cases where you can all have a short glance on how DIA Elvivo solution has indeed improved the clinical workflow, saved measurement time, and assist physicians in taking their decision. Professor Liel, please.
Thank you, Adi, and thank you, Alexis, and hello, everyone. The first patient I will present is a 25-year-old man admitted to the COVID-19 department with high fever, weakness, chest pain, and dehydration. Later on, the patient developed also dyspnea. The request was made for an urgent echocardiogram, and in order to minimize the exposure time of the sonographer to the patient, the measurements were not done during the exam. The examination was sent to the PACS system and also to the Elvivo Seamless system for urgent evaluation, and the results were available on the PACS for immediate review. For immediate review by the echocardiographer as he opens the patient's file. As you, whoops, sorry. As you can see on the Dia's AI-based solution, Elvivo EF automatically measured the ejection fraction from 4 and 2 chambers views, and the result is seen at the bottom as 45%. On the PACS workstation, as you can see on the video, the Elvivo RV was used to measure RV strain that was found to be -20. So the physician's conclusion was that the patient may have myocarditis due to COVID-19 affecting the LV and that the RV function is normal. So the patient was treated accordingly. The case shows how using Elvivo Seamless can minimize exposure of the medical staff to the COVID patient as it improves and speeds the workflow, and that accurate and automated evaluation enabled fast diagnosis and appropriate patient care with minimal exposure of the medical staff to COVID-19 patients. The next patient is a 52-year-old woman with breast cancer treated in a large center by chemotherapy, complains to her GP of shortness of breath. As we are all aware, some chemotherapeutic drugs may cause gradual and significant LV dysfunction, and thus repeated echo studies are recommended by the guidelines, preferably by the use of the same application. The GP referred the patient for an echo exam, and the study was sent to the Elvivo Seamless system for automatic analysis. And again, you can see here the video with Dia's Seamless AI-based solution automatically and quickly measured the EF as 48%. And also the GLS, as you can see in this video, a GLS from 3 views, both indicating mildly abnormal ejection fraction and strain. The results were available and reviewed by the echocardiographer at the PACS workstation as he opened the patient's file. Prior echo examination was also available on the PACS, and the echocardiographer could review it as well by the Elvivo system installed on the PACS station, which uses DICOM clips from any vendor. The prior EF was 55%, and the prior strain was 19%, using the same application. The diagnosis was reduced ejection fraction and global longitudinal strain in this oncology patient treated by cardiotoxic chemotherapy, and importantly was also shown to be mildly reduced when compared to the results from the prior exam using the same application. Thus, the patient should probably be referred to a cardiologist who may consider starting treatment for preventing further LV dysfunction from developing, and also need evaluation with her oncologist regarding her chemotherapy treatment. Follow-up echocardiography of her LV function, ejection fraction, and global longitudinal strain, as recommended by the guidelines using the same system, is available with Elvivo for past, current, and future exams. So we can see here that the automated Elvivo Seamless system enables to identify early signs of LV dysfunction in chemotherapy patients, and to compare them to prior exams with the same application for patient follow-up regardless of the vendor used. The Elvivo Seamless system enables standardization in evaluation and thus improves patient care. Here we briefly show some of the validation for our tools. All the applications of the Elvivo platform have FDA clearance and are CE approved. In each study, data from 100 patient examinations with normal and abnormal cardiac function were collected from different medical centers. We were using different ultrasound devices in the studies, and the clinical validation for each tool was done compared to routine measurements. High correlation results were obtained compared to reference for all solutions. And for more details about the studies, you are welcome to visit the DIA's website. And in conclusion, to sum up, the automated pre-selection of use and EF and strain measurements are all done behind the scenes. It enables minimizing exposure time to patients during the exam and thus reduces the risk of infection. The application is vendor neutral and saves measurement time. This automation helps us to reduce the variability associated with manual measurement and improves the workflow, as the seamless workflow is involved from the acquisition to the immediate reporting. Thank you very much for this opportunity to present you with DIA's tools. Thank you. Whoops. I didn't show the last slide. Hold on a second. I lost the control, I see. Whoops, here. Thanks.
There you go. Thanks so much, Noah, and to everybody for a great set of presentations. What we're going to do now is come to some of the questions, and thanks to everyone for sending those through. So I'm going to ask our panel to turn their cameras back on, and we'll go through some of the questions that people have shared. Omer, are you still with us? Well, there we go. Excellent. Just before we go into that, just confirm to everyone this session will be available on demand from next week, so you will be able to watch the presentations back in your own time if you want to do that. Now, I'm just going to go through some of the questions that we've received in kind of order, going back to JP's presentation first of all. There are a couple of specific questions for you, JP. The first one around accuracy and precision, which is often a key factor for clinicians when considering this kind of solution. So can you speak a little bit to that for us, please?
So thank you very much indeed for that question. So there's a question about whether a measurement is precise and accurate, i.e. is the measurement a true measurement of the actual value, and how precise is that measurement around that accurate value. So it's basically looking at sort of a bullseye, homing in on the true value to make sure that you've got the correct answer. There was a lot of work done on this by a number of groups actually. So first of all, Stefan Peterson, who I've talked about, who is essentially leading the MRI part of the UK Biobank Imaging sub-study. There is a free access article in the Journal of Cardiovascular Magnetic Resonance in 2018 in September, which looks at the DICE index, so how accurate the machine is versus the human supposed expert, and they have very, very clear protocols, very complex protocols against how you measure ventricular volumes and function. So the DICE metrics are very high, above 0.94 for the LV cavity, and also the bland Ortman plots, which I showed you. I can't share my screen, unfortunately, but you can see really good agreement on bland Ortman plots in terms of variability about the true expert-derived value. So the question is whether the expert gets it right. We're assuming that the human expert is correct, but there is very, very good agreement in terms of both accuracy and precision. And remember, the variability between scans is completely abolished because the machine will always do the same thing every time. I hope I've answered that one. There are other groups who have also looked at that. So there's another paper from, where is this one? So again, in the National Journal of Cardiovascular Imaging, similar sort of issues. Apologies, I'm just trying to get back to the control from that side of things. So yeah, in the answer to that question, a lot of work is done and it does show very good agreement.
Okay, thanks, JP. There was another specific question about changes in hemoglobin concentration, the impact on cardiac activity and blood flow, whether they need to be adjusted accordingly. Can you speak to that briefly? And then I've got a question for Omer as well.
You know, this is a very interesting one and an area that I know relatively large amount about. Specifically, but looking at people who are very anemic versus those who are not, and the case in point is patients with thalassemia. And we know very clearly that if you are anemic with thalassemia, then your left ventricular end diastolic volume is going to be high, your stroke volume is going to be high, your ejection fraction should be higher than other patients. So if you're anemic, that does have a significant impact on cardiac function from left ventricular and right ventricular point of view. There's a paper by Mark Westwood in JCMR a long time ago now, pre-2010. I also wrote on the right ventricle around about the same time. So we do know that hemoglobin does affect cardiac size, cardiac function. You would expect to have higher volumes and ejection fraction from that point of view. In terms of blood flow, yes, you'll get a higher stroke volume and therefore a higher cardiac output. It does also affect relaxometry times. Iron overload can affect T1. We're not talking about blood oxygen level dependence, but we're talking about sort of iron dephasing the spins from that point of view within the myocardium itself. So if you've got anemic patients, they are expected to have higher volumes, higher ejection fraction and dynamic circulation. If they have normal or low normal, then you're potentially in trouble. So I hope that has answered that question. Back over to you, Alexis.
Thanks, JP. And Omer, during your talk, there was a question about whether there's been any application of the technology within newborn cardiovascular disease. Has there? And if there has, can you tell us a little bit about it?
Like we are not primarily focusing on the congenital cases or the birth defects. So our methods are not trained on those cases, but we have been doing some augmentation with our with our training strategies, scaling the hearts, because it's like a baby heart is like a very different anatomy than the adult heart. So we have seen that we perform not too bad on those cases, but we are still like not claiming that we should be applicable on those cases.
Okay, thanks, Omer. And to move on slightly, so one of the great sort of applications here, and the benefits here, as we sit here and now, is in terms of time saving in clinical practice. And I wanted to ask JP and Noah respectively, kind of where you see the biggest benefit in terms of time saving within your practice. Noah, this application within Echo, kind of where's the, where are you seeing the greatest time saving, the greatest benefits?
I think that once we have these tools and we get used to use them and trust them, because there is always an interface between the clinician that sees the tools and believing in the results. And once we have it, then really quickly we move into using them and having a second opinion. So we always, when we look at the echo, we use it quickly, we use it, and we compare it to what our eyes is seeing, and usually it gives us a second opinion that we can trust, or that we can think, do we believe in it, or do we need to do some changes? This is one thing. The other really important thing is our seamless system that really enables the echocardiographer, when he opens the file of the patient, to immediately get the results of the analysis. And then immediately he has some idea what is his ejection fraction. Of course, I think everyone is still reviewing all the clips and making sure that it fits in, but in the future, it may shorten our time as we do it. Also, the sonographers don't have to do all this analysis on the machine, not the strain, not the ejection fraction, and not the RV. We can use our tools and repeat them or correct them if we are not sure it tracked the walls well enough. So in many ways, it will shorten the time of the sonographer on the machine. Then they can move to the next patient, and it shortens the time for the cardiologist analyzing the exam. And of course, for the for the fellows that are less experienced, it is also a very important tool.
Thanks, Noah. And JP, you wanted to come in on another point, I think, just before I get your perspective on the time saving.
I'll talk about the time saving first, actually, because it is really important for us, because when you look at a scan, you can tell within seconds exactly what you're going to say in your conclusion. So you just have a very quick overview and you know exactly what you're going to say, but actually getting from the images through the analysis. When we first started 10 years ago, we were drawing circles on systole and diastole and left ventricle and right ventricle. It took ages, really takes ages. And then you go through and you work out your conclusion and then write your report. With the systems from Circle now, it's all done before you even open the study. It's automatically uploaded to the report. You can export that in HTML or HL7 to your PAC system, to your radiology information system. And so, there's a huge amount already done for you. And I think it's about 15 to 20 minutes in terms of time saving, where you can visually say, yep, this is hypertrophic cardiomyopathy, but getting from the point where you're analyzing the data to proving it is often the time-consuming bit. So substantial time saving. The other thing that I was just going to say about the question on congenital heart disease is, if people are interested in that, have a look at Vivek Mutarangu's work and Oliver Tan and the team at Great Ormond Street, because they have done an awful lot of work in terms of speed up hugely quick scanning and very rapid assessment and reporting. So that's a very interesting group to review from that point of view, if you're interested. Back to you, Alexis.
Thanks, JP. What I've realised is, don't you know, in the blink of an eye, we've reached the end of our allotted time. What I'd like to say to everybody who's put questions through that we didn't get to, thank you so much for doing that. And what we'll do is endeavour to share them kind of post-webinar with our panelists as well, so that they're not going to go unanswered. But for now, it really is all we have time for. So I must take the opportunity to thank our excellent panel, as well as Circle CVI, and of course everyone for joining us. Again, just to let you know that this session will be available on demand at ai-med.io from next week. But for now, I've been Alexis May for AI Med. We look forward to welcoming you to the next in our series of AI Med live webinars. Thanks again. See you soon.
Thank you so much.
Thank you,
Thanks,
guys.
everybody.
Bye.
Thank you. Bye.